I'm Andrew Matthews from the University of Pennsylvania, and at this year's ASH, we present a retrospective cohort study comparing outcomes for CPX-351 versus venetoclax and azacitidine in adults with newly diagnosed acute myeloid leukemia. This study builds on a background of research that has consistently shown that frail older patients do not benefit from intensive chemotherapy. On the other hand, what we don't know is what is the best induction therapy for older adults with stable comorbidities. So in this study, what we sought to do was directly compare a primary outcome of overall survival for CPX-351 versus venetoclax and azacitidine using two data sources, the University of Pennsylvania Health System, electronic medical records, as well as the Flatiron database. What we found is that in 656 patients overall, of which a 2-to-1 ratio had received venetoclax versus CPX-351, the primary outcome of overall survival showed no difference between the two therapies. The hazard ratio was 0.88 and 95% confidence interval crossed 1. We actually also looked at a univariate analysis of multiple different baseline covariates and did not find any particular subgroup of patients that benefited more from one therapy than the other. We also sought to examine whether or not this held true across a series of sensitivity analyses. We restricted the overall population to the patients who would have been eligible for the CPX-351 pivotal trial, and again, found no difference in overall survival. We also sought to overcome the traditional hurdles of retrospective studies with multiple imputation and inverse probability of treatment weighting. In univariate analysis, we found, again, no difference in overall survival between the two groups. Using multiple imputation, we found no difference between the two groups in multivariate Cox regression analysis. And in multiple imputation with inverse probability of treatment weighting, we found no difference between the two arms. The key takeaway from our study is at this point, there is no large efficacy difference between the two arms. This is similar to other work presented at this year's ASH, which showed no significant difference between CPX-351 and venetoclax and azacitidine once we control for baseline imbalances and covariates. The key question then remaining for us as a field is how do we choose between these two therapies? We also analyzed some key secondary outcomes regarding adverse events. When we did this, we found that the CPX-351 group had a higher rate of febrile neutropenia, infection, and length of stay in the hospital. While these analyses are preliminary in terms of adverse events, we think that they're important to keep track of in future studies. The other key factor in this study is that the rate of transplant between the two arms significantly impacted overall survival. While there's no difference in overall survival between the two groups, transplant remains key for this patient population. So in conclusion, we found in a large, multi-center, well-powered national retrospective cohort study, no difference in overall survival between CPX-351 and venetoclax and azacitidine as initial therapy in acute myeloid leukemia. There are two major paths forward. One is a prospective trial randomizing patients to these two therapy choices, and the other is replication by other centers assessing the CPX-351 versus venetoclax and azacitidine. Finally, we also know that this is an area where we're going to continue to need new treatment options for our patients. But for now, the choice between these two therapy options will require replication or prospective trials.